Good morning. Today we have a 4-month-old child with right side incomplete cleft lip and cleft alveolus. Is also a case of tracheoesophageal fistula with congenital heart disease. He was operated for tracheoesophageal fistula immediately after birth within first 15 days. So this kind of a cases are bit high risk cases, and today we are going to do primary cleft lip and nose repair, like primary kiloplasty and primary rhinoplasty. Primary rhinoplasty using a septal cartilage as a alar rim graft. So most of the time the parent asks us, how are you going to close this lip? Are you going to harvest some skin from other part of body? Or a lot of laymen, they ask whether you are going to use some plastic, because they consider this is plastic surgery, and doctor use some kind of a plastic. So all these things are myth in the society. There is nothing like, in cleft lip and cleft palate surgery, we do not use any kind of a plastic because it's not a practical solution, and very rarely we might have to use some skin graft, but not as a routine process. Usually all the structures are there, but during birth they are not united properly. So we have to properly identify all the structures, and we have to advance the both side cleft segment and join them together, and we have to keep in a mind to match all lip structures precisely to get normal anatomy of lip. There are various techniques used for cleft lip repair. I follow modified Millard techniques with few of my personal modifications, and we try to recreate normal looking lip. Mainly we try to match white roll precisely. We try to recreate the filtral depression, we try to recreate filtral column, and we try to recreate the normal fullness of the vermilion margin. And with this modifications, I am able to get a normal looking lip in most of the cases.